Okay, so let's start the class. Good morning, everyone. So today I'm going to continue the same discussion which we started last time, that is cerebrovascular disease or stroke, also known as cerebrovascular accident. Now, if somebody asks you what is the definition of CVA, then you can answer this is a sudden onset neurological deficit which occurs because of occlusion of blood flow to area of the brain or because of rupture of the blood vessel which supply that area. Okay, so this is the very correct way of defining stroke. Listen once again. This is sudden onset neurological deficit because of either occlusion of the blood flow, which is known as ischemia, or because of the rupture of the blood vessel which supply that area. Now, what are the different types of stroke? So see here, thromboembolic infarction almost comprises 80% of the cases, cerebral and cerebellar hemorrhage 15% of the time, and subarachnoid hemorrhage is also part of the stroke, around 5%. And then among them, what are the common causes? See here, the large vessel occlusion, either internal carotid artery itself or the branches of internal carotid artery like middle cerebral or anterior cerebral. They are quite common to occluded in almost 50% of the cases. Some other lacunar infarct, cardiac emboli, blood disorders, or vasculitis. So all of them can lead to formation of thrombus, okay, or embolus, which can block the blood flow leading to infarction. This is the way. So we'll talk about this in detail in the subsequent slides. Another type of stroke is a hemorrhagic stroke, either cerebral or cerebellar hemorrhage. Okay, it is less common than the infarction, and these are the common causes. Hypertension, the systemic hypertension leads to hypertensive bleed in almost 60% of the hemorrhagic stroke. Some other causes may be amyloid angiopathy, deposition of amyloid substance on the blood vessel wall leading to weakness. Vascular malformation, also known as AV malformation, and some of the bleeding disorders or diathesis also can be caused by anticoagulants like warfarin and heparin overdose or overuse. The last one is subarachnoid hemorrhage. Okay, less common. It is commonly caused by aneurysm. This is called Berry aneurysm almost 80% of the time. Sometimes vascular malformation or AV malformation, and sometimes even non-aneurysmal subarachnoid hemorrhage, which can be directly caused by hypertension. Okay, so these are the types of stroke. Let's move on. Another types of classification for us is clinical classification. Now, clinical classification would be transient ischemic attack, TIA is the first one. The TIA, okay, see here, the term itself suggests transient, means it is for a particular duration, for a short duration, and that is within 24 hours. So whatever a deficit has occurred, it will completely resolve within 24 hours. This is called TIA. We'll talk about the different example later on. Right now, okay, for the better understanding, I like to take few of the name here, like amaurosis fugax. Amaurosis fugax means sudden blindness, okay, sudden blindness, sudden onset blindness. There is a dark curtain in front of the eye. So people complain like that, and they definitely go to the hospital, and to everybody's surprise, within 24 hours, the person will regain vision again. So this is a very good example of TIA. Reversible ischemic neurological deficit is the second one, also known as RIND, reversible ischemic neurological deficit. In this condition, the neurological deficit completely resolves within a period of 1 to 3 weeks. It resolves within a period of 1 to 3 weeks. Okay, this is the second variety. Now, the third one would be stroke in evolution or progressive stroke. Now, what happens in this case? There is focal neurological deficit which worsen after the patient first present. Means day by day, probably it will go worse and worse, or it will become worse and worse over a period of time. This may be due to increasing amount of infarction inside the brain, hemorrhage, or related edema inside the brain. So this is called stroke in evolution. And the last one is a completed stroke right from the beginning. Okay, this is a complete type of stroke, and there the focal neurological deficit persists and is not progressing anymore because it is already complete. Okay, it's already complete, and this is the most severe type of stroke. So this is called clinical classification, how the patient manifests in the hospital. So accordingly, we have classified stroke. Now, before we go on to the discussion of different things, okay, other related things in the stroke, let's talk about differential diagnosis of stroke and TIA. Now, I'm sure every student know by this time what is differential diagnosis. Differential diagnosis means the clinical features may be similar in different conditions, like primary brain tumor or primary cerebral tumor. Now, this brain tumor or cerebral tumor is a space-occupying lesion inside the brain. Okay, this is a space-occupying lesion inside the brain. So, any space-occupying lesion inside the brain will cause raise ICP. It will cause seizure, okay, headache, and some of the features may match with stroke. So that's why it can be considered as a differential diagnosis. Now, if your examiner or professor asks you how to differentiate them, take the name of some investigation like CT scan or MRI. Another is metastatic cerebral tumor. From somewhere else, the tumor has metastasized into the brain. Okay, especially in adult, this is quite common in terminal cases of cancer. Subdural hematoma. This is a clot formation in the subdural space. Okay, quite common in alcoholic people. Again, some of the clinical feature would be same because it also causes raised intracranial pressure. Peripheral nerve lesions like vascular or compressive. Now, stroke causes neurological deficit, and this peripheral nerve lesion also cause problem in the nerve, which is called neuropathy. So a bit similar. Cerebral abscess or brain abscess, another cause of focal neurological deficit, which also causes raised ICP. Torts paresis or torts paralysis. Now, after generalized tonic-clonic seizure, okay, after generalized tonic-clonic seizure, the patient will become unconscious, and during the recovery time, the person also has paralysis of the limb. This is called torts paralysis or paresis. So it almost looks like uh, uh, TIA or stroke. Usually TIA because this also completely recover after few hours. Demyelination, okay. Demyelinating disorder. Can you give me one example of demyelinating disorder? Yes.
Alzheimer, Parkinson disease.
Yeah.
Multiple sclerosis. Multiple sclerosis.
Very good.
Multiple sclerosis.
Very good. So I already got the answer from you. Excellent. So there are two very good example you can give. In the central nervous system, multiple sclerosis is a perfect example of demyelinating disorder, and in peripheral nervous system, it's Guillain-Barré syndrome. So Guillain-Barré syndrome, peripheral nervous system, okay, multiple sclerosis, central nervous system. The Alzheimer disease and the Parkinson disease are known as degenerative disorder, okay, not demyelinating, degenerative disorder, because there is a death of the neuron itself. Now, hypoglycemia, very important, differential diagnosis of stroke, because in severe hypoglycemia, there is coma. Okay? Coma can occur in hemorrhagic stroke and massive type of ischemic stroke as well. Seizure also occur in both conditions. So we have to rule out hypoglycemia, and it is very easy. Just order blood sugar level and you will diagnose hypoglycemia very easily, and treatment is also very easy. Now encephalitis, meningitis and other intracranial infection, they also present with seizure and coma. So it can be considered as a differential diagnosis, but usually it is also associated with fever, and fever is not seen in case of stroke. And lastly, conversion disorder. Now this is a psychiatric condition where, okay, a person without any organic disease inside the brain, okay, presents like paralysis. There is no explanation for the paralysis here. There is no neurological deficit anywhere, or the causes of neurological deficit I should say, like no intracranial lesions, okay, no infection, nothing, but still that lady is unable to move the limbs. This is called conversion disorder. It is considered as a type of psychiatric disorder. So these are some of the important points in the exam, a common question for the students. Okay, now let's move on. Okay, see here. So before I go further, let's talk about what are the risk factors of stroke. Now, this is a very easy question for every student, but such an important one. Most of the time we ask this question in the exam. Okay. Now remember, not always we ask difficult question in the exam. Okay. Sometimes the easier one also would be asked. Now we divide them into non-modifiable and modifiable risk factors. Now see here. Non-modifiable and modifiable. Now, non-modifiable means we cannot do anything. Okay, if it happens, it will happen. Like age, it's not under our control. So, a stroke is commonly seen in older age. Regarding the gender, it is more common in male. Okay, but in older female, also a stroke can occur because the risk factor for atherosclerosis are also quite common in postmenopausal female. Hereditary factors, okay, they run in the family, so not under control, and the previous history or previous vascular event which has already occurred in the past, like MI, okay, one past episode of stroke or even peripheral embolism, there is very high chance of recurrence once again. And these are the important non-modifiable risk factor. Now from the exam point of view, these modifiable risk factors are even more important. Now see here, high blood pressure or hypertension which is uncontrolled, okay, diabetes mellitus, hyperlipidemia or dyslipidemia, and smoking. These four, I will talk about heart disease a bit later. Okay, high blood pressure, diabetes, hyperlipidemia, and smoking. These four are the most important modifiable or potentially controllable risk factors for atherosclerosis. That's why they are also important risk factor for stroke. Now, heart disease. Look at the example here. Atrial fibrillation, heart failure itself, cardiomyopathy, mainly the dilated type of cardiomyopathy, and even infective endocarditis. All of them can result in embolization from the heart. So whenever embolization occurs in the cerebral circulation, there is a high chance of obstruction of blood flow to one particular part of the brain, resulting in stroke. So this is the correlation there. Obesity, important risk factor. Excessive alcohol consumption or alcoholism, you can say. Okay. Polycythemia, any causes, any disease which leads to increased RBC concentration, that is called polycythemia, either primary or secondary, are associated with increased thrombus formation. So it is considered a risk factor. And OCP use in female, this is also associated with thrombus formation. So all of these are risk factors. So please revise them unless you are quite clear about them. Let's move on. Now, What is the pathophysiology of stroke? This is very easy. You already know this mechanism. There are three important mechanisms which may be existed. One is embolism, another is thrombosis, and third is hemorrhage. So this embolism and thrombosis comes under ischemia. So if I want to, write in an easy way, I may write like this. Okay, the two important mechanisms are ischemia and hemorrhage. Ischemia and hemorrhage. Now for this ischemia, I'll again divide this ischemia under two parts. Okay, I'll again divide this ischemia under two parts. Now this is thrombosis. Okay, thrombosis is one, and another one is embolization. Now if you remember like this, you will never forget. Okay, embolization as well as thrombosis. Okay, now share. Okay, now see there. So ischemia and hemorrhage. Okay, we roughly divide the pathophysiology into two big group. Then ischemia can be caused by thrombus formation as well as embolization, and hemorrhage is another important point. Now this ischemia, apart from this thrombosis and embolization, okay, very rarely can be caused by vasculitis also. Vasculitis. Okay, so this is another small mechanism involved there. Now see that what I was talking, less commonly, okay, less commonly carotid or vertebral artery dissection. This is because of trauma. This arterial dissection is mainly because of trauma, and this arterial dissection will definitely block the blood flow there. This is very rare type of mechanism. Polycythemia already talked about, which leads to hyperviscosity syndrome. Thrombosis is very common there, so it directly comes under thrombosis. Fat and air embolism, it's a type of embolism. See there, mass lesion like brain tumor, abscess, or subdural hematoma, which directly compress the blood flow. So this is a direct compression, or probably because of edema formation, they compromise the blood flow. And rarely arteritis as well as neurosyphilis. Arteritis is a type of vasculitis. That's what I was talking. See there, arteritis, a part of connective tissue disorder, and neurosyphilis, a tertiary stage of the syphilis. And in that condition also there is end arteritis obliterans. So let me write that mechanism for you so that you will never forget. End arteritis obliterans. This is the mechanism of blood vessel blockage in case of syphilis. So because of this, again, there will be ischemia development. So these are some other less common mechanism. Okay, now with this information, now let's move on to the what are the overall or general clinical features of stroke. Now please pay attention quite well. Okay, mute yourself and focus on the screen here. Now stroke is all about the presence of a neurological deficit, and that neurological deficit means, okay, it is mainly a motor deficit, means there is paralysis, motor deficit, and another one is dysfunction of the higher function of our brain, like cerebral function deficit. A good example are aphasia or neglect. Aphasia or neglect. Okay, we'll talk about this a bit later. All these neglect and aphasia would come back again when we move on to the middle cerebral artery occlusion and things like that. Okay, now aphasia actually means loss of speech. Loss of speech, in the last class also I clearly told you about this. Loss of speech, okay, is caused mainly by Broca's area problem. Now there are two important areas of speech in our brain. Can you take the name of those two areas?
Wernicke's area and
Broca's.
Wernicke's area.
Very good, very good. Broca's and Wernicke's area. Excellent. Broca's and Wernicke's area. Okay, these are the two speech area in our brain. Now listen very carefully. If somebody is speaking, for example, I am explaining something and you guys are listening, first of all, you should understand what is the meaning of this. Then only if I ask you the question, you can answer me. So this comprehension or understanding is done by Wernicke's area, and whatever answer you have, you will give with the help of Broca's area. So there is a good connection between Wernicke's area and Broca's area inside our brain. So what happens first? We listen the thing. It will be analyzed by Wernicke's area. The input will be given to the Broca's area, and then the speech will come out. So this is all very good coordination going on between these different speech area. Please mute yourself. I can still hear some noise there. Now neglect means, okay, neglect means it's a negligence of one half of the body. Okay, the patient behaves like that part of the body doesn't exist. Okay, it is there, but patient thinks it doesn't exist. So whatever happens on that side, patient will neglect that. For example, if patient goes to shave the beard, okay, on that side, patient will forget to shave. This is very interesting type of mechanism. On a plate, okay, patient is eating rice, for example, the plate is a circular one. On one side of the plate, okay, there is a rice. Patient will neglect that. Patient will not even touch that because that area is neglected. This is called cerebral neglect. And listen very carefully here. Now aphasia occurs if dominant cerebral hemisphere is affected. For example, I am right-handed person. So the dominant cerebral hemisphere in me is the left cerebral hemisphere. So if left cerebral hemisphere is having stroke, then aphasia, okay, occurs very commonly. So similarly, cerebral neglect occurs if non-dominant cerebral hemisphere is affected. So exactly opposite to each other. Similarly, some other clinical features also occur like ataxia, okay, ataxia, diplopia, vertigo, or bilateral weakness, which usually indicate a lesion in the brainstem or cerebellum. So because these are the center, okay, which control this movement. So if these centers are affected, then this abnormality will appear in the patient, like ataxia, diplopia, vertigo, or even bilateral weakness. Now this bilateral weakness occurs if the whole brainstem, both on the right side and the left side, would be involved. Then only there would be bilateral weakness. Otherwise, there will be crossed hemiparesis. Okay, cranial nerves are affected on one side, and the paralysis occurs on the other side. But if the whole thickness of the brainstem is affected, both on the right as well as left, then there would be bilateral weakness of the body. Now let's talk a little bit about reduced consciousness level. Now this is a very common clinical feature in the stroke, especially if there is a large volume lesion in the cerebral hemisphere. This definitely leads to reduced consciousness level, sometimes even coma. Okay, and many other time it is caused by some complications like hydrocephalus, okay, hypoxic damage of the brain, or severe systemic infection as well. Okay, so there are so many different causes of a coma. Stroke is just one of them. Let's move further. So all of you please have a look there. Now what are the main problem or differentiation in hemorrhagic stroke and ischemic stroke? Now see this, there is a rupture of the blood vessel. You can clearly see here, okay, rupture of the blood vessel. Let me is the pointer. So for example, this is a blood vessel here. It has ruptured. There is a leakage of blood here. Okay, this is called hemorrhagic stroke. This is a schematic diagram which is explaining very nicely. And this is a ischemic stroke. There is a small clot which stops the blood flow, and this whole area is dead now. This area is necrosed. So ischemic stroke versus hemorrhagic stroke. Now, in both type of stroke, headache would be there, okay, vomiting would be there, and probably drowsiness and loss of consciousness will also be there. But these are much more common in hemorrhagic type of stroke than in ischemic stroke, because hemorrhagic stroke leads to a formation of space occupying lesion there because of the blood clot formation, and that space occupying lesion will cause all the clinical features much more severely. Okay, so this is a very, very important clinical knowledge you should have. For example, you are working in the emergency room. Suddenly one patient of the stroke was brought there. Now at that moment you want to know which type of stroke is this, and this type of clinical feature will really help you. But that is not the final judgment. Okay, the final diagnosis or judgment is done by CT scan. You have to take CT scan, and that will give you the final diagnosis. Now let's examine this patient overall. Now we don't only examine the disease, the overall, what are the risk factors there, what are the clinical features of those risk factors, is there any signs there or not. So we need to examine the whole patient. So let's start from the skin. Now some of the points are very familiar to you. Okay, so let's discuss them. In the skin, on the skin, there may be xanthelasma. Okay, so xanthelasma is a feature of which condition?
Hyperlipidemia.
Hyperlipidemia.
Very good, very good, excellent. That's what I told you. Many of the students already know that. And this is a feature of hyperlipidemia. Hyperlipidemia. This hyperlipidemia has some important clinical features which are there on the body. So if we find those clinical features on the skin, we can ask the patient to go for lipid profile test, and the dyslipidemia or hyperlipidemia can be diagnosed quite early. So these are xanthelasma, which you have just seen there. Okay, xanthelasma. Then xanthoma. Okay, xanthoma, th, xanthoma, and arcus senalis. Or you can also call it lipid arcus. So these three are very common clinical feature or sign of hyperlipidemia. Never forget it. Xanthelasma is mainly present on the upper eyelid or towards the medial canthus of the eye. Okay, slightly towards the upper eyelid. Xanthoma is present over the tendon. There is solid type of deposit of lipid over the tendons. It almost looks like a tumor there. Xanthoma. And arcus senalis is present on the peripheral part of the cornea. Arcus senalis. Now there may be rashes present. Rashes. These rashes are rashes of connective tissue disorder. That's what we wrote here as arteritis. Or they may be there may be features of infective endocarditis, because in infective endocarditis there are different type of rashes. Okay, one of that is splinter hemorrhage, which occurs on the nail bed. Another is petechiae and purpura itself, which are important clinical feature of infective endocarditis. Okay, there may be Janeway lesion, there may be Osler node, isn't it? So different things are there. Examine for limb ischemia or examine for deep vein thrombosis features, because they are commonly associated with a stroke case. Now let me explain by giving you different association or connection here. The same pathophysiological mechanism which causes stroke can result in peripheral arterial disease also, and that is the cause for limb ischemia. The same type of thrombosis, the same type of embolization, the same type of atherosclerosis, which may be occurring in different parts of the body. Quite easy type of answer. And then deep venous thrombosis, a paralyzed patient. If the paralyzed patient, okay, is bedridden for a long time, and if we do not take care of that patient properly, means the massaging of the body, the regular turning of the body is not done, then what happens? There is a high chance of deep vein thrombosis. And another correlation can also be there. In deep vein thrombosis, especially if there is a septal defect inside the heart, the patient may suffer from paradoxical emboli. Okay, it is called paradoxical emboli. That means it has originated from the deep vein of the lower limb, but that small emboli has bypassed the septa, okay, that is interatrial septum or interventricular septum, and enter onto the left side of the heart, and from there it has gone into the brain. So see there. So this is how you can give explanation when your teacher asks you. Now let's talk about what are the clinical feature we get in the eye in a stroke case. There may be diabetic change, which is known as diabetic retinopathy. Diabetic retinopathy, very important clinical feature, because diabetes is an important risk factor for atherosclerosis, which can cause cerebrovascular disease. So that's the connection. And one more point here, in severe and prolonged type of diabetic mellitus, there may be peripheral neuropathy. And remember, cranial nerves are the example of peripheral nerves. So who knows, there may be already a neuropathy of third, fourth, or sixth cranial nerve, and having, affecting those nerves, the patient may having diplopia. So that's the connection with diabetes and connection with cerebrovascular disease. Retinal emboli, very important feature of infective endocarditis. Okay, infective endocarditis. Hypertensive change. If hypertension is a risk factor, it can lead to hypertensive retinopathy. And arcus senilis, we already talked about. Now, regarding the cardiovascular system, okay, these are the important examination we need to do. Check the blood pressure and make sure patient is hypertensive or not. Very, very important risk factor. Check the heart rhythm, okay, auscultate or examine the pulse very nicely, or try to find out where atrial fibrillation is there or not. Now, there's a small question I like to ask to you. What is the connection between atrial fibrillation and stroke? Yes?
Lead to embolization.
Fibrillation of emboli in heart. There is embolization for
Stasis.
Dislodge of the
Blood gases in the arterium and then
Exactly.
lead to the embolization.
The
Exactly.
neural thrombi will detach.
Exactly. All of you are absolutely correct. All of you, okay? I can clearly hear your answer. So the answer is there may be already thrombus formation inside the heart, because atrial fibrillation occurs in diseased heart, like rheumatic heart disease or congenital heart disease or ischemic heart disease. So there is a high chance of thrombus formation already, which is called mural thrombus. On top of that, when fibrillation occurs, there is detachment of that thrombus and turn into embolus, which is known as thromboembolism. Now, it can easily go into the cerebrovascular circulation and resulting in stroke. So never forget it. We have to examine atrial fibrillation. Now, atrial fibrillation is very easy to diagnose by examination and investigation. Even ECG is very, characteristics of atrial fibrillation. So when we do ECG, okay, there will be irregular rhythm. There will be no P wave, and these are called fibrillatory wave. Let's move on. We have to auscultate for the murmur also. Okay. This murmur indirectly tells us probably heart is the cause of this stroke, because Murmurs are commonly heard in rheumatic heart disease or congenital heart disease, and probably there is the source of embolism. Even in infective endocarditis, there is murmur. Okay, and infective endocarditis is another common cause of embolism. Look for JVP, okay, or jugulus venous pressure or jugulus venous distension, which is a feature of right-sided heart failure, and this is decrease in hypovolemia. It doesn't increase, but decrease in hypovolemia. And remember, hypovolemia is one of the conditions which exacerbate the features in stroke. It exacerbates if it is there in the patient. And never forget to palpate peripheral pulses and bruit. Now, peripheral pulses we need to palpate. Okay, after the break, I'll again highlight that. And bruit is murmur-like sound which occurs in peripheral arteries. Okay, it occurs in peripheral arteries. That is called bruit. Bruit is commonly associated with stenosis or narrowing of the artery. Now, there are certain important peripheral pulses in the upper limb and lower limb. Can you answer that? Yes?
Yes, sir.
Radial pulse.
Radial pulse, femoral.
Very good. Yes. For a head and neck region, we palpate carotid pulse. Okay, we palpate carotid pulse. From the upper limb area, we palpate brachial and radial pulse. Brachial and radial. And from the lower limb area, we palpate femoral, popliteal, dorsalis pedis, and posterior tibial. Femoral, popliteal, dorsalis pedis, and posterior tibial. So these are the different names of peripheral pulses. Every student should know about them and how to palpate them. Remember, okay, not only the name. Your professor can ask you how to palpate those pulses, so you should be familiar with the process. And bruit means it's almost like a murmur which we hear in the artery as a result of stenosis or obstruction. So these are some of the important things in the cardiovascular system exam. Let's move on. Now see this slide, okay, is telling us about the different signs you can see, okay, in hyperlipidemia. Signs you can see in hyperlipidemia, which we already talked about. See this? So can you tell me what is this first one? What is the first one?
Arcus senalis.
Arcus senalis.
Excellent, excellent. This is arcus senalis, okay? Arcus senalis. If you look very carefully at the circumference of the cornea, at the junction of sclera and the cornea, which is called limbus, there is white type of deposition, lipid. This is xanthelasma. Xanthelasma, more commonly in the upper eyelid, but also seen in the lower, and both of these are towards the medial canthus of the eye. This is called medial canthus. So this is xanthelasma, this is xanthoma, and this is also xanthoma. So arcus senalis, xanthelasma, and the last two are xanthoma. All of these are signs of hyperlipidemia. So lipid profile test has to be ordered in the patient to confirm whether there is hyperlipidemia or not. Now, some other examination of a stroke case, okay, we can do our respiratory system exam just to make sure whether there is pulmonary edema or not. Now, remember, what is the connection? Pulmonary edema is present in case of heart failure, especially in left-sided heart failure. And heart disease and heart failure is commonly associated with stroke. So that's why we have to make sure whether it is present there or not. Respiratory infection is very common in a stroke case because they are usually in coma. They are usually having depressed consciousness level. They cannot cough. They cannot clear their airway. So chance of respiratory infection is highly common. Examine abdomen for urinary retention. Okay, the comatose patient sometimes has urinary retention. So probably the urine is staying there inside the bladder. The bladder is full. Okay, so we need to put catheter there to drain the urine. This has to be examined first, then only you can put the catheter. Another is examine for the locomotor system or the motor system to find out whether there is paralysis or not, and whether there are some comorbidities or not. Sometimes the patient may fall with a stroke and presents with injury or fracture also. So all of these are different examination of a stroke patient. Now let's move further and let's talk about something else, that is how to differentiate between anterior circulation occlusion and posterior circulation occlusion. Or you can answer like this if this question is asked: what are the differences between the clinical feature of anterior circulation impairment and posterior circulation impairment? Now, anterior circulation is known as carotid territory and posterior circulation is known as vertebrobasilar territory. This is important point. Every student know that. And if anterior circulation is blocked, it can result in blindness. This is monoocular visual disturbance or blindness on one eye, okay, which is quite common than both, because blockage on one side is much more common than on the both side. That is the meaning. Another is speech disorder. Now this is speech disorder is because of involvement of the Broca's as well as Wernicke's area. Upper motor neuron type of 7th cranial nerve palsy, very common manifestation. Very common manifestation in case of anterior circulation block. Please mute yourself. Hemiplegia and hemianesthesia both are quite common as a result of cortical type of involvement. Now, cortical means the cerebral cortex is affected. Probably the precentral gyrus and postcentral gyrus, if both are affected, a big area, then both hemiplegia and hemianesthesia can occur. Whereas in posterior circulation impairment, there would be diplopia, okay, diplopia because of involvement of the nuclei of cranial nerve 3rd, 4th and 6th. There may be vertigo or dizziness. Patient can have drop attack, okay, sudden loss of the tone, dysphagia, dysarthria. This is scanning type of speech. This is not same as aphasia. Aphasia is impairment of Broca's or Wernicke's area leading to loss of speech. This is dysarthria. The sound is there, but we cannot really understand what the patient is speaking. Broken or scanning type of speech. There may be bipyramidal sign lesions, which is known as double hemiplegia, or if posterior, okay, posterior cerebral artery is blocked, okay, then cortical blindness can also occur. So these are some of the important points regarding anterior and posterior circulation impairment. Now, one important question which the teacher like to ask are the examples of transient ischemic attack, or what are the features of TIA in anterior circulation side and posterior circulation side. Now see there, okay, pay attention. In carotid system blockage or involvement, amaurosis fugax is very common one. This is sudden onset of blindness, okay, sudden onset of blindness. Aphasia can be there, hemiparesis can be there, and hemisensory loss can be there. But remember the definition of TIA: within 24 hours, all these neurological deficit will recover towards the normal. What are there in the posterior circulation side? Diplopia, vertigo, vomiting, choking and dysarthria. These are because of involvement of the cranial nerves. Ataxia because of involvement of cerebellum. Hemisensory and hemisensory loss, okay, because of involvement of some sensory tract there. Hemianopic visual loss, okay, this is hemianopia. I'll explain this. It's a little bit difficult for you, so let me explain with the help of a diagram. And tetraparesis, all 4 limbs are paralyzed. Tetraparesis, are also known as quadriparesis. So this can happen if the whole thickness of the brain stem is disease. Now, just one side involvement of the brainstem never results in tetraparesis. So this is an important point. Okay. Now, let's talk about cerebral infarction. So we are entering into the different types of stroke now. So let's talk about them one after the other. So the first in our list is cerebral infarction or ischemic stroke. Now, the cause of cerebral infarction is mostly due to thromboembolic disease. Now, everybody know this, okay, by this time, and it is mainly secondary to atherosclerosis. Now, where this atherosclerosis commonly occur? Okay, this is in the major extracranial arteries. That is carotid artery. This is the most common site for atheroma or atherosclerosis. It can also occur in the aortic arch. About 20% of the infarction can happen from embolism from the heart. Probably there is some prior heart disease in the patient, like rheumatic heart disease, ischemic heart disease, congenital heart disease, cardiomyopathy, and there is a formation of mural thrombus, and that turned into thromboemboli, and it has gone to the brain. So this is the mechanism. Other 20% of the case, probably the perforating arteries which are going very deep inside the brain. One of the important example is called lenticulostriate artery. Now this lenticulostriate artery supplies internal capsule and basal nuclei region. So if it is blocked, there is dense type of hemiparesis on other half of the body. This is also known as lacunar infarction. Okay, lacunar infarction. Remaining percentage of the cases may be because of vasculitis or endocarditis. So these are important points. Now, if they ask you what are the risk factors for ischemic stroke, okay, you can answer the same risk factor which we discussed in the risk factor of generalized stroke case. That means risk factor for atherosclerosis first, then risk factor for thrombosis, and risk factor for embolization as well. So all the risk factors should be there one after other. Okay, so this is how, okay, you talk about the risk factors in a case of stroke. Let's move on. Now, if a cerebral infarction occurs, then what are the different stages that infarct will go through? In the beginning, what happens, and subsequently how it will progress further. Immediate to 6 hours, there is no change both grossly and microscopically. Now it has a very important clinical, okay, correlation. That means immediately after the patient comes to the hospital with ischemic stroke, if we do CT scan up to the 6 hour, probably CT scan would be normal. There would be no change in the CT. So you need to repeat it after some time if we strongly suspect this is an infarction or ischemic stroke, because it takes time for the changes to appear in the brain. Now another one is acute stage. It may occur up to 2 days. Now during this time there would be edema, there is loss of gray-white matter border. We cannot really differentiate it, and microscopically there would be inflammation with a lot of neutrophils infiltration. So edema is the main feature in acute stage, and we can now see this very clearly with CT scan. After that, up to 2 weeks time, the intermediate stage would be there, and during this stage, okay, there is soft friable tissue development, and it is quite clearly demarcated from the normal brain. So we can clearly see the border there now. And at this stage, regarding the microscopic feature, there will be infiltration by macrophages, and there is formation of liquefactive necrosis. Now, if we go back to your pathology, then There are different types of necrosis. One of them is liquefactive necrosis, and whatever disease occurs in the brain, the only necrosis that can happen is a liquefactive one. And the reason for this is there are lots of hydrolytic enzyme inside the neuron. Those hydrolytic enzyme will be released outside and they will liquefy that area of the brain. This is called liquefactive necrosis. After 4 weeks, okay, the late stage would begin or occur, and during this time there would be gliosis now. Now gliosis, can you tell me what are the example of glial cells in the brain? Glial cells, yes?
Microglia.
Microglia,
Microglia cells,
Astrocytes.
astrocytes.
astrocytes,
Oligodendrocytes.
Good, good. So I already got your answer. So let me write those important points here. Some of the students have already answered very correctly. So these glial cells are mainly known as macroglia and microglia. Now let's take the name of macroglia first. These are astrocytes, okay, oligodendrocyte, okay, dendrocyte, oligodendrocyte, and ependymal cell, okay. So these are the important example of microglial cell. And microglia, okay, is a type of macrophage. So if you take the name, you are right there, it is called microglia. It's a type of macrophage, but that macrophage doesn't involve itself in the gliosis. Only the microglial cells involve themselves in the gliosis. It is just like fibrosis which occurs inside the brain. Now there would be formation of fluid filled cyst, okay, in the late stage. The removal of tissue is done by macrophages. The important macrophage is microglia there, and I already explained what is gliosis there. So these are the important point regarding okay, the infarct stages after cerebral infarction. Now we are moving on to the very important and probably a little bit difficult part, that is the clinical features of infarction or cerebral infarction or ischemic stroke. Now let's discuss this with a typical stroke syndrome. Now if middle cerebral artery is occluded, what are the clinical features? Now out of 3 important cerebral artery, these are anterior cerebral, middle cerebral, and posterior cerebral. The middle cerebral artery is the most commonly occluded in a case of stroke. And if this question is asked in the MCQ paper, you can clearly solve it now. So it is MCA which is the most commonly affected. Now to answer this question, you need to remember the territory or the areas of the brain which are supplied by middle cerebral artery. Now see here, if it is occluded, there will be contralateral hemiplegia. Contralateral means opposite side of the body. Hemiplegia is 1/2 of the body is paralyzed. That means the upper limb and the lower limb on that side is paralyzed. Another is hemianesthesia. There is sensory loss on opposite side of the body, and there is homonymous hemianopia. Okay, now there is visual problem. Homonymous hemianopia. Now let me explain this, a homonymous hemianopia. But before I go there, I like to ask you one question here. Why it is contralateral hemiplegia? Why not unilateral or the same side?
Because of decussation.
Because it will cross each other.
It will decussate in the brain stems.
Very good. So see there, many students are answering, and the answers are correct as well. Now listen here, for so many, because we cannot ask question to every student here, okay, and there will be a lot of disturbance if I do that. So listen carefully. We are talking about the brain now, okay, inside the brain. from the brain, the corticospinal fiber they start, and then they descend downwards. So from the cerebral hemisphere, okay, they are known as corona radiata. Then they will go onto the internal capsule. From the internal capsule, they descend downwards and they enter into the brainstem. First, in the midbrain, okay, in the midbrain, they are called cross cerebri or cerebral peduncle. Then they will enter into the pons, okay, and from the pons they enter into the medulla. Now in the medulla there is pyramid. This is very important structure because in pyramid majority of the corticospinal tract fiber they decussate and descend on the other side. Now they decussate means they cross over and go to the other side. That's why if a particular part of the brain is affected, for example left side of the brain is affected, the paralysis occurs on the right side of the body because of the decussation in medulla. So never forget this golden statement. Now let's talk about what is this homonymous hemianopia. Now see this, okay, in ophthalmology, when we reaches 9th semester, we'll again teach you about this, but right now you need to have a concept. So all of you please focus here. Now this L means left eye, this R is right eye, okay. Having said that, this is left retina and this is right retina, isn't it? So these are the retinal fiber which are going as a optic nerve. So this is the optic nerve we are talking about. This is left sided optic nerve, this is right sided optic nerve. This optic nerve has two important types of fiber. This green is called nasal retinal fiber and this blue are temporal retinal fiber. Now please have a look here. This nasal retinal fiber are crossing over and going to the opposite side, okay, right here they are crossing, but temporal retinal fiber they do not cross, they go on the same side. This is absolutely important knowledge. Now, okay, let's come to the point. If there is a lesion here exactly on this side, the person cannot see completely with this eye because both retinal fiber are damaged. Both retinal fiber means nasal fiber as well as temporal fiber. But if only this is damaged, see there is no complete blindness in one eye because this fiber contains temporal fibers from the same side and nasal fiber from the opposite side. So the person will have homonymous hemianopia. Homonymous hemianopia if the lesion occurs in this area. Now what do you mean by that homonymous hemianopia? Now see this here. Look at this picture here, okay. This means, for example, it is a left eye, this is right eye, okay. Now the same side on the both eye are blind, same side. See here, okay, this is also on this side, it is also on this side, but we call it temporal side and nasal side because for this eye, this is the nasal side, for this eye it is a temporal side. So on left, okay, eye there is temporal loss of the vision and on the right eye there is nasal loss of the vision, but they are on the same side of the visual field. This is known as homonymous hemianopia. Homonymous hemianopia. Now, there is one other very important term which I like to highlight. If the damage is occurring right here in this region, okay, in this region where the nasal retinal fibers are crossing over, then the patient suffers from bitemporal hemianopia. Bitemporal hemianopia. Now why bitemporal? Okay, now see here, you have to pay attention a little bit more here. The retina, okay, the nasal part of the retina is receiving, okay, vision from the temporal field of vision, and temporal side of retina, okay, is responsible for nasal field of vision. Now we are talking about the visual field now. Okay, see here in this picture. Okay, please focus here, this picture. Now see this is retina. Here is retina. Okay, this is the visual field. Now this is the temporal retina, isn't it? Temporal retina. So from where it is getting the vision? From the nasal visual field. Nasal visual field is on this side, temporal is on this side. So the nasal retina is getting visual field from the temporal side, but temporal retina is getting visual field from the nasal side. So exactly opposite to each other. And whenever we talk about this visual defect, we always take reference of the visual field. We don't take the reference of retina. That's why the terminologies are like that. So these are a little bit difficult point for you. So what I suggest is to please go back after the class. You need to pick up one neurology book, textbook, look and study this visual pathway very well first. Okay, know everything about the visual pathway and then try to know about the abnormal thing. First is always normal. Now let's go back. We have not even discussed some important points there. Now another important thing is when the dominant cerebral hemisphere is affected. Now dominant cerebral hemisphere is depends on which handed person you are. Are you right handed person or left handed person? So majority of the person or people in this world are right handed persons. So their left cerebral hemisphere is dominant. Okay, so if it is the scenario, then there is global aphasia. When dominant cerebral hemisphere is affected, there is global aphasia. Global means both Wernicke's area as well as Broca's areas are gone as a result of MC occlusion. Both are supplied by middle cerebral artery. So the patient will have aphasia now. There is no comprehension and there is no speech. Another one, when the non-dominant hemisphere is affected, for example, in right-handed person, the right cerebral hemisphere is the non-dominant one. In this regard, there is constructional apraxia and cerebral neglect. Now, cerebral neglect, I already talked about. And constructional apraxia means that person will forget whatever he has learned before. Okay, for example, the person was a very good driver before. He completely forget about that. The person forget about drawing. He used to be a very good artist before. He completely forgets about that. So this is called constructional apraxia. So these are the things which occurs when the non-dominant cerebral hemisphere is affected because of MCA occlusion. Let's move on. Now, another part of this discussion is about ACA occlusion. ACA means anterior cerebral artery occlusion. What happens if this is blocked? Now see this picture first. These are the areas which are supplied by anterior cerebral artery. This is mainly the medial surface of cerebral hemisphere. This is medial surface. A small strip, okay, on superolateral surface is also supplied by anterior cerebral artery. So we need to remember that when we explain the clinical features. Now let's come to the point. If ACA is occluded, there is paralysis of opposite foot and leg area only, because the motor leg area is only supplied by ACA. This is important point. Now see here, this is the leg area. Now why is this leg area? Okay, so we need to answer according to the motor homunculus. That motor homunculus is an inverted type of person. The head okay, is downwards and the foot is upward. It is going slightly on the medial side also, and that is the area which is supplied by anterior cerebral artery. That's why the foot and leg area are paralyzed on the opposite side. Never forget this. At the same time, there is loss of the sensory, you know, sensation in this area also. There is urinary incontinence because the urinary bladder area is also controlled by anterior cerebral artery territory, and there is impairment of gait and stance again, okay, because of involvement of frontal cortical area, which is very near to the motor leg area. So there is impairment of gait and stance, means standing position of the patient is also abnormal. So these all are different clinical features of ACA occlusion. Very importantly asked in the exam. Now the easier one for you, what happens when posterior cerebral artery is occluded? There is homonymous hemianopia and there will be cortical blindness. There is homonymous hemianopia and there is cortical blindness. But one important point is there which I like to highlight, that is there is macular sparing. Okay, macular sparing. Now anybody knows what is macular sparing and why this happens? Anybody, any student?
Because central vision is preserved.
Yes, Rana Atisam, yes.
Sir, macula has no supply of blood.
Which are those arteries? Which are those arteries?
Sir, from posterior cerebral artery and sir, medial cerebral.
Very good. So I give one chance to Saad Parvez also, because he was also speaking. Yes, Saad, what is your answer here?
Sir, the same macula has macular part of occipital lobe has dual blood supply, posterior cerebral artery and middle cerebral artery. So
Very good, very good. So both of them are absolutely correct. Okay, this is an important question which may be asked to the students. Remember this: among this cortical blindness, there is a macular sparing, because that area of the occipital cortex, okay, which is gaining, okay, gaining vision from the macula. Macula means this is the area inside the retina. This is the area which receives the most acute type of vision, most sharpest type of vision. So those fiber will go to that particular area, and that area is supplied by two arteries, okay, middle cerebral artery and posterior cerebral artery. So even if posterior cerebral artery is completely blocked, middle cerebral artery is still supplying that area, so that is sparing of the macula. Very important knowledge. Now, okay, so with these clinical features, let's go and talk about some easier part. What investigation we like to do in a case of acute stroke case? So here, some of the investigations are baseline investigation, which we order all the time in every patient, and these are complete blood count and ESR. Now, complete blood count is important here because polycythemia can be diagnosed by CBC. If hemoglobin concentration is very high, if RBC concentration is increased, that is polycythemia, and that is one of the risk factor of stroke. That is one answer you can give very confidently. Another one, okay, another one is in case of intracranial infection like meningitis and other sort of intracranial infection, there is a high chance of thrombus formation in intracranial blood vessel, and that thrombus formation also can lead to stroke. So CBC would be abnormal during that time. ESR, okay, is high in case of connective tissue disorder. One of the important example is temporal arteritis or giant cell arteritis. Serological test done for syphilis. Now I want some answer here. What are those serological tests?
PDRL.
PDRL.
Good. VDRL and VDRL or RPR, okay? Isn't it? VDRL or RPR? VDRL or RPR. Excellent. Now these are called, okay, these are called screening test for syphilis, or they are non-tryponymal type of test, and they are sensitive but not specific. So some other specific tests are also there. Anybody tell me the name there? What are the specific tests in the diagnosis of syphilis? Any few example?
PCR.
Okay. Now see there. This is a little bit new question for you. So listen. Okay. This is called FTA absorption. FTA absorption test. FTA means fluorescent tryponymal antibody absorption test. This is one. Another is called TPHA test, Treponema pallidum heme agglutination assay. Okay, and another one is TPI, Treponema pallidum immobilization test. So all of these are called specific test for syphilis, and if they are positive, the diagnosis is there for the 100% of the time. Now on the other hand, you can also go for blood glucose analysis. Now every student can answer this. Blood glucose is done for two things. Okay, so what are these?
Hypoglycemia and diabetes.
Hyperglycemia and
Hypoglycemia.
hyperglycemia.
Exactly.
Hypoglycemia and
Hypoglycemia.
hyperglycemia.
Exactly. Hypoglycemia and hyperglycemia. So hypoglycemia, there are coma, there are some neurological deficit only because of hypoglycemia. And even more important is the diagnosis of diabetes, because hyperglycemia is the most important point in diabetes, and diabetes is a very important risk factor for cerebral infarction. Blood urea nitrogen and serum creatinine, this is a part of renal function test, because CRF or chronic renal failure also leads to hyperlipidemia and resulting in the stroke. So we need to make sure how kidneys are functioning. Chest x-ray, you need to rule out heart disease, heart failure, pulmonary edema. So chest x-ray is an important type of investigation. ECG and echocardiography, same explanation you can give to rule out heart diseases. And carotid Doppler, that means what is the amount of blood flow in the carotid artery? Is it really narrowed or not? So all these information are obtained by Doppler study of the carotid artery. Okay, so these are some of the important baseline investigation. Now there are some other important or special investigation which we like to do, and these are mainly important in young adults. So let me explain this for you. Stroke is more common in the older people, we all know that, and that is mainly because of atherosclerosis, the risk factor for atherosclerosis. But sometimes if a young patient develops a stroke, then we think about some other causes as well, like connective tissue disorders, like familial hyperlipidemia, okay, isn't it? So to find out that, we need certain other tests, and these are ANA, anti-nuclear antibody, and anti-double-stranded DNA. Now tell me, which disease is diagnosed by this investigation? Which is that disease?
SLE.
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 Very good. Okay, all of you
SLE.
know. All of you know that SLE. SLE or systemic lupus erythematosus is diagnosed by this, and among them ANA is very sensitive test for SLE diagnosis, whereas anti-double-stranded DNA is very specific test. One is sensitive, another is specific. Try to remember this. Another is called lupus anticoagulant and anticardiolipin antibody. Both of these are done for the diagnosis of antiphospholipid syndrome. Antiphospholipid syndrome. So let me write that here. Both of these are done for antiphospholipid syndrome. Okay. Now, this antiphospholipid syndrome is an abnormal condition in our body. It is connected with some sort of a connective tissue disorder where abnormal blood clot forms in different parts of the body. So it is about abnormal thrombosis. Okay, thrombosis occurs in different parts of the body. So there will be ischemia. If same thrombosis occurs in our cerebral circulation, here also problem will happen. Lupus anticoagulant may be present in SLE as well. Now, serum cholesterol. This serum cholesterol is a part of normal investigation and a part of special investigation as well. If a young person, for example, the person is just 30-year-old, okay, 30-year-old patient develops a stroke. Now, sometimes a disease known as familial hyperlipidemia might have run in the family, and in that condition there is very high LDL and cholesterol level. Just to diagnose that, we have mentioned it here. Now let's move on. After we talked about these important investigations, okay, another one are the radiological investigation now, like CT scan. CT scan is absolutely mandatory uh, in the management of stroke. Now, why? Let me explain this. Whenever a patient was brought or is brought to the emergency department where you are working, and you believe this patient is having stroke because the family member give typical history. The patient was sleeping nicely, but suddenly in the morning time the patient complains weakness of the one side of the body. Okay, this is a very typical history, and patient cannot move that part. Now I want to make sure whether this stroke is ischemic or hemorrhagic before I start my treatment. If I fail to make the correct diagnosis and treat the hemorrhagic stroke as ischemic one and ischemic stroke as a hemorrhagic one, okay, the patient would be dead. Now, why I'm saying this? See there, in ischemic stroke, we usually use aspirin drug. But if it turns out to be a hemorrhagic stroke, and if you give aspirin, it will be a catastrophic, consequences. Similarly, the opposite thing you can give reasons. Okay, so proper diagnosis has to be done, and CT scan will help us to do that. So CT scans are of two types: plain CT scan and contrast enhanced CT scan. I'm sure you have already studied this in radio diagnosis. Now we do plain CT scan whenever this type of patient comes to the hospital. Plain CT, it doesn't take long time, and plain CT will definitely show hemorrhagic stroke. Now see here, hemorrhagic stroke is diagnosed immediately, whereas infarction takes 48 hours to diagnose. Definitely, the infarction needs some changes to occur there, but that blood clot can be seen right there instantly by plain CT. So if there is no blood clot seen in CT scan, probably we think this is a ischemic stroke. So like that, you can rule out. At the same time, you can also rule out some secondary causes which are known as differential diagnosis of stroke, like tumor, brain tumor, vascular malformation like AB malformations, okay, some aneurysm, all those things can also be seen. Now, please focus here. This is the a normal CT scan slice of the brain. Okay, so let me use the pointer here. Yeah, this is the front of the head, this is the back of the head. Okay, this is the normal CT scan of the brain. You have to note the density here. This is the normal density of the brain. Now, some dotted line are also shown here to make sure that you identify the correct area. This area, just compare the density between this area and this area. See here, this is called hypodense area. Hypodense area. So this is highly suggestive of ischemic stroke. But remember, whenever the patient comes, if we do CT, we do not see this type of lesion. It takes at least 48 to 72 hours to see this type of area. So don't say, oh, there's nothing seen, so patient is normal. We never say like that. We admit this patient because patient is having clinical feature. Patient may be having hemiplegia of one half of the body. Okay, patient may be having aphasia, something like that. Admit the case and repeat CT scan after 48 to 72 hours. You will definitely see this type of thing. Let's move on. Now, another CT scan. Okay, so see there, this is hypotenuse area. You can clearly see hypotenuse area here. So this is ischemic stroke. This is the normal density of the brain. This is hypotenuse area. Now, what is the role of MRI, magnetic resonance imaging, MRI? So MRI is preferred in cases of posterior fossa infarction and for patients who are having TIA or transient ischemic attack. So MRI is always done for posterior fossa lesion inside the cranial cavity, as well as if you believe some soft tissue, some other which are quickly resolving, if something is happening to the spinal cord area, spinal cord itself, then MRI would be preferred over the CT scan. Regarding another type of investigation, angiography can be done, but this is not routinely done in the clinical practice because it takes time. It is considered a relatively advanced type of investigation, and it is used to rule out specific cause like arterial dissection, which is a rare causes of stroke. Arterial dissection mainly occurs because of trauma and connective tissue disorder once again. So angiography can be done. Now with this, let's talk about how to manage a case of stroke, or what are the general management of patient with acute stroke. So these are the aims of management, or you can also call it goals of treatment. We want to minimize the volume of the brain that is irreversibly damaged. Now, what type of tissue is neuron? In the basic science, we have talked about these different types of the tissue. So what type of tissue is this? Neuron. Can it recover or regenerate once it is damaged? Yes or no?
No, sir.
No, sir. It cannot
No, sir.
regenerate
It will not regenerate.
Very
because
good.
it made from oligodendrocyte.
Okay, very good. So it cannot regenerate, but it will be replaced by glial tissue. And these glial tissue are astrocyte, oligodendrocyte, and ependymal cell. We talked about this before. So brain is made up of neurons. These neurons are called permanent cell. Once these permanent cells are damaged, they cannot regenerate themselves back. So they are replaced by glial tissue. Now, once it is damaged or dead, it is dead. We cannot do anything there. But because of some secondary changes, there will be other damage done in the surrounding area. Now, I'll give you one good example here. There is a clot formation inside the brain, or there will be one area of ischemia inside the brain or infarction inside the brain. Now, surrounding that area, there will be edema. That edema will cause raised intracranial pressure. Now, that edema and raised intracranial pressure will damage other normal area of the brain as well. So, we want to minimize all these things. The first type of damage is called primary damage. This type of damage is called secondary damage. Both should be minimized by the management. So this is our aim. Another one, to prevent the complication. There are so many complications of the stroke. We'll talk about that. Third, reduce the patient's disability and handicap through rehabilitation. Now, disability and handicap, these are the important terms. These are probably you have studied this in the preventive and social medicine. I'm not sure about that. So disability and handicap. So let me quickly, talk a little bit about them. Now, the person was fine before. After cerebrovascular accident or stroke, the person has developed paralysis of one half of the body. Okay. Now, person cannot walk. That is called disability. That is called disability. The person has become disabled now. And as a result of this, okay, the person has lost the job which he was doing before, because he could not move the upper limb. They are paralyzed, cannot walk. So because of that disability, the company has fired that person. That is a handicap situation. So disability is usually associated with handicap situation. Now, we cannot do much, but we have to treat those type of patient by rehabilitation, means physiotherapy. This is one of the very important aspect of stroke management. The person can still use a little bit of the limbs by physiotherapy. Another one, reducing the risk of recurrent episode. Now, what does that mean? The risk factors of the strokes are still there. The person may be still a smoker. He may be a diabetic patient. He may be a hypertensive patient, hyperlipidemic patient, obese patient. So the future episodes of the stroke has to be minimized by treating those risk factors. So these are some of the important aim. Now see there. So let's go further. Let's talk about how to treat ischemic stroke now. So all of you, please focus here. So let's talk one after other. Here, treat the complications of bedridden patients like pneumonia, urinary tract infection, bowel and bladder care, and prevent DVT or deep vein thrombosis. These are quite common type of complication in acute stroke case. Pneumonia, okay, because the person is drowsy, the person may be in coma, the cough reflex is not present during that time. So the secretions from the respiratory tract may be collected there. Pneumonia is very common. UTI, we have to catheterize a patient who is in coma because of stroke. Catheterization attract urinary tract infection. Okay, so the person cannot, pass the stool properly now. There may be incontinence or there may be constipation, who knows. So bowel and bladder care has to be done properly, and because of the immobility, DVT chances are quite high. And what is the complication of DVT? Why we are afraid of DVT? Yes?
Pulmonary
Pulmonary embolisms may
pulmonary embolism.
blood may be discharged, may
Pulmonary
go to the
embolism.
lungs.
Very good.
Pulmonary ischemia.
Very good. So all the students are answering quite correctly. This is pulmonary embolism and pulmonary infarction. Pulmonary embolism and pulmonary infarction. That is the danger of deep vein thrombosis. So we need to be careful. So prevention has to be done. Frequent massaging, okay, frequent positioning, change in the position of the patient, and then use of anticoagulant drug like heparin and warfarin are very much essential. Let's move further. Now for those who are unable to swallow or tend to regurgitate or aspirate, put an NG tube and start feeding. Now many of these patients are drowsy, okay, and they don't have sense, so they cannot swallow, or even if they try to swallow, there is high chance of regurgitation or even aspiration. That's why do not feed a patient who is drowsy or who is in coma. Do not put anything in the mouth. There is a high chance of aspiration. Rather than that, we put NG tube, okay, and through the NG tube we start feeding, because this patient is going to stay a long time in the hospital or even at home. Feeding is very much essential. So NG tube feeding has to be done, okay, in this situation. But if the person can swallow, remember, if the person can swallow, if the person can talk, okay, he can identify people, he's asking for food, probably you don't need NG tube. you need some help from the other people. Probably they should feed that person with the help of a spoon or something like that. Another is control of blood pressure. Hypertension is one of the very important risk factor of stroke. Even in ischemic stroke, remember, the patient may be hypertensive. Not only in hemorrhagic stroke, also in ischemic stroke, the person may be hypertensive because it's an important risk factor for atherosclerosis. So continue the same drug which the patient was taking before. Continue the same drug. Probably you need to adjust the dose of the drug because the blood pressure was not controlled. Okay. Now, don't use new drug unless blood pressure is very high, like more than 220, over 120. This is in the range of malignant type of hypertension. Lowering the BP suddenly may decrease cerebral blood flow, and if I suddenly decrease the cerebral blood flow, there would be secondary damage done inside the brain. Now remember, earlier I talked about primary damage and secondary damage. Primary damage has been done already, but secondary damage can be done by this type of mechanisms. Decrease blood flow later on by the use of medicine. So we need to be careful. That's why we often say, do not decrease the blood pressure suddenly. Now let's move on. Another type of therapy which we can do is avoid hematocrit level more than 45%. Now why? What is the danger of this? If hematocrit level is very high,
Polycythemia
Polycythemia, weakness of the viscosity of
leads to ischemic stroke.
excellent, very good, excellent. We are concerned about polycythemia. If hematocrit or hemoglobin is very high, it means there is polycythemia. It leads to increase viscosity of the blood, and that can aggravate ischemia further. So avoid this. And if there is polycythemia, you need to go for vein section. Okay, take out a bit of blood from the vein, and that will decrease the hematocrit or hemoglobin level. This is called vein section. This is the treatment. Control of blood sugar between 100 to 200 milligram. Maintain hydration and electrolyte balance. Okay, this is a very easy to understand. Infarctions are complicated by late cerebral edema. I already explained this. So to decrease the cerebral edema, we need to use mannitol. We need to restrict salt and water intake. Whenever there is edema inside the body, you need to cut off sodium as well as excessive water intake. And mannitol is a type of osmotic diuretic which is very commonly used in the management of increased intracranial pressure and cerebral edema. So mannitol is a good drug here. If the patient is in coma, okay, then use oxygen. Try to maintain the oxygen saturation over 95%. This is a universal type of treatment. We always provide oxygen if a patient is in coma. Maintain temperature less than 37 degree. Now this is known as therapeutic hypothermia. Now our brain cells, we need to decrease the metabolic rate in the brain cells during this time because the brain is suffering here. So if we maintain hypothermia, then the metabolism in those neurons, the cerebral neurons, will be decreased, and that's what we want in this type of situation. So sometimes you will be surprised to see, see here, you'll surprised to see they cool the head till 32 degree also, just to decrease the metabolism in those neurons so that they recover faster. Okay, this is the point. Let's move on. There's so many other things we need to talk, like what are the medicines now? These are all the general management. So what are the medicine we want to use in the treatment of ischemic stroke? Antiplatelet drug like aspirin or clopidogrel, they are very routinely used. aspirin or clopidogrel. Aspirin 325 milligram per day, but remember these aspirins or clopidogrel, they are contraindicated in hemorrhagic stroke. That's why I clearly told you before you start your treatment, make sure which type of stroke is this by CT scan. CT scan is absolutely mandatory. If there are some other bleeding lesion inside the body like bleeding peptic ulcer, aspirin and those type of drugs are not given. Now anticoagulant therapy is a very important therapy here. Anticoagulant, because this is ischemic stroke, maybe who knows, this is associated with thrombosis, okay, or embolism, isn't it? So for those, anticoagulation is very much essential. Now look at here, it is indicated in cardiac emboli. Cardiac emboli here in the presence of atrial fibrillation or thrombus in left ventricle. Now, if a patient is having mitral valvular disease like MS or MR, then atrial fibrillation is very common, and from that dilated left atrium, there may be release of cardiac emboli. This is one condition. Another one, in case of prior ischemic heart disease, okay, the left ventricle may be a source of thrombus, which is called mural thrombus. So overall, heart may be a very important source for emboli. So if that is the situation, and if we have diagnosed it before, then we need to give heparin in the beginning, okay, and continue with warfarin. Heparin in the beginning and continue with warfarin. The target INR, called international normalized ratio, is 2 to 3. Okay, we need to maintain the INR in this range, otherwise there will be bleeding. Bleeding is the complication of warfarin. Okay, we all know that bleeding is a complication of warfarin. So INR should be maintained at 2 to 3. Now, what is the role of thrombolytic therapy? Now, thrombolytic therapy. Now, thrombus has already formed. We want to break down the thrombus so that the blood can flow there again. This is the principle. Okay, so which are those drugs which can break the thrombus? Yes, give me the names.
Streptokinase.
Streptokinase.
Nice.
Histoplasminergic activate.
Nice. So many students are answering quite properly. Very good. It is written also here. Streptokinase, urokinase, and tissue plasminogen activator, TPA. Streptokinase, urokinase, okay, and tissue plasminogen activator. TPA is very commonly used in the clinical practice. Now let's talk a little bit more about them. They are frequently associated with hemorrhagic transformation of ischemic stroke because they lyse the thrombus, and if they lyse it a bit more, you know, that's always that always can happen. This is called side effect or adverse effect of the medicines. So they may transform that ischemic stroke into a hemorrhagic one. They can be tried if a patient presents quite early, within 6 hours of the onset, before that thrombus is organized. Now, if you remember, in the topic of myocardial infarction, I clearly told you during that class as well. Whenever a patient comes quite early, in case of, okay, transmural type of infarction or ST elevation MI, then only we go for fibrinolytic therapy or thrombolytic therapy. If the patient comes quite late, you know, the failure of fibrinolytic or thrombolytic therapy is very high. Rather than that, they cause a lot of adverse effect. So same principle can be applicable here also. If patient comes quite early to the hospital, you can give a try. But if patient comes late, don't use this type of drug. Now, these are the complications of acute stroke. Okay, so see there's so many. Some of them we already mentioned before. Chest infection or pneumonia is one of the important one. Epileptic seizure, okay, because brain is damaged, there may be a source of epileptic seizure now. Deep vein thrombosis and pulmonary embolism, we already know about this. Painful shoulder, okay, also known as frozen shoulder, painful shoulder or frozen shoulder because of immobility of shoulder joint for a long time. This is another type of complication. Pressure sore or bed sore formation, very important complication in a case of stroke. This is caused by failure to manage the case properly, because we cannot blame the patient. We cannot say, oh, this patient is paralyzed, so bed sore will develop in that patient. Nothing like that. Okay, this is the job of ours, the healthcare personnel or family members. We need to keep on turning the body of this patient every 2 to 3 hours, so that one particular part of the body is not pressurized all the time, and that is the cause of pressure sore or bed sore. Urinary infection, very common complication. Constipation and depression as well as anxiety. If the patient even recover from the acute stroke, the paralyzed body will never come back. Okay, he can never recover in the previous situation. Now maybe slight function of the paralyzed limb would be coming back because of physiotherapy, because of rehabilitation, but complete recovery is impossible. So because of this single point, depression and anxiety would occur in the patient. Okay, so these are some of the complications, and these are very easy. You can go through this on your own. Actually, a bit of difficult things I like to highlight here. Okay, now one important point I like to highlight here is this epileptic seizure. This epileptic seizure is quite common after a case of stroke. It can occur during the acute stroke, or it can occur later on as a sequelae of the stroke. So for the prevention, we have to maintain good cerebral oxygenation and avoid the metabolic disturbances during that time, like maintain the sodium level, okay, maintain the glucose level and all those things. And treatment is anticonvulsant. Now, one simple question I like to ask to you: whenever a patient is seizing, okay, in front of you in the emergency department, the patient has seizure, which drug you use to control that seizure immediately? Which drug?
Diazepam.
Infusion.
Diazepam.
Benzodiazepine.
Benzodiazepine or diazepam.
Diazepam is
Excellent. Okay, all of the students are answering the same. Very good. This is benzodiazepine or diazepam. The example of benzodiazepine is diazepam. Okay, you can go for lorazepam as well, but diazepam is very commonly used. Excellent. Now please listen carefully. That is our next topic. After I finish stroke, I'll move on to the seizure disorder, but right here I want to mention something, that benzodiazepine is not given for a long-term management of the seizure. It is only given to control that seizure during the time. So we need to take, or we need to start some long-acting anticonvulsant drug like phenytoin, phenobarbital, sodium valproate, or carbamazepine. These are first-line anti-epileptic drug. So they are still very good drug. So many doctors still wants to use this drug for the long-term control of seizure. And if they do not work properly, then they are always second-line drug. So this is the concept. So you should get those concepts from the class. Now another important point which I like to highlight is a pressure sore. So prevention is frequent turning of the patient every 2 to 3 hours and monitor the pressure area. Now, which are the pressure area in the patient when the patient is lying supine on the bed? Very easy question. That is the back side, isn't it?
back
Side of the
of
back
the
side.
patient.
Very good. Exactly. One is occiput area, okay, on the head. It is occiput area. This is directly a posterior occiput area. Another is blade of the shoulder, okay, blade of the shoulder or even scapula. Then buttock area. very important one, buttock area, then heel area. These are the pressure areas when the patient is lying supine. Now think of a situation. If there is no frequent turning of the patient, then they can easily develop into pressure sore. Pressure sore are also known as bed sore or ischemic sore. So important point. Now, regarding the UTI, we need to avoid catheterization if possible. But this is a challenge now. If we do not, put catheter, then patient will pass urine on the bed, and this will further cause pressure sore. So rather than the Foley's catheter, okay, we can use penile sheath, or also known as condom catheter in case of male. Now it can be applied very easily, and it doesn't has a high chance of causing urinary tract infection. So this is important, and if it has already occurred, treat with antibiotic. Regarding the depression and anxiety, maintain the positive attitude and provide information. This is a preventive aspect. A lot of counseling is necessary. We need to explain the whole disease process to the patient, and what they can do later on. Okay, and the same counseling should be given to the family member as well, wife, son and daughter, who are going to take care of this patient now, because this patient cannot move properly, patient probably cannot feed properly, so somebody has to be there at home to take care of. And if it has already happened, take the help of the medicine like antidepressant or anxiolytic drug. If anxiety is there, use anxiolytic drug, and if depression is there, go for antidepressant. Benzodiazepines are a very good example of anxiolytic drug again, and antidepressant. After going through the management and complications of acute stroke, especially the ischemic type, let's talk about how to reduce the further stroke in the future, how to reduce the risk of that further stroke in the future. Now, before that, let's talk about what is the risk. The average risk of a future stroke or further stroke would be 5 to 10% within the first week of a stroke or TIA. See, this is quite a high percentage. 5 to 10% within the first week of a stroke or TIA, 15% in the first year, and 5% per year thereafter. So there is a good chance that future or further stroke can happen later on. So to prevent from that, we need to prescribe certain drugs like antiplatelet drug, aspirin or clopidogrel every day. And if the patient is having dyslipidemia, then you have to prescribe simvastatin or atorvastatin type of drug, so that can be under control. Never forget the risk factor for atherosclerosis. Control blood pressure, quit smoking, control diabetes, control obesity. All those things has to be done. Now with this, let's enter into the discussion of hemorrhagic stroke. Hemorrhagic stroke, and that hemorrhagic stroke is mainly divided into two types: intracerebral hemorrhage and subarachnoid hemorrhage. So let's talk one after other. Intracerebral hemorrhage means blood collection or blood clot formation inside the cerebral hemisphere, okay, inside the parenchyma of the brain. Now, what are the common anatomical site? They may be putamen, okay, putamen. Putamen is a part of what?
Lentiform nucleus.
Basal
Lentiform
nuclei.
nucleus.
Basal
Very
nuclei.
Lentiform nucleus.
nice, excellent. So you can also say putamen is a part of basal ganglia or basal nuclei. Very good. It is mainly divided into chordate nucleus and lentiform nucleus. So putamen is a part of lentiform nucleus. Excellent. So see there, it is quite a common site for intracerebral hemorrhage. Lobar means the cerebral hemisphere itself. Thalamus, chordate nucleus. You don't need to remember the percentage for everything, okay? Which is more common, just remember that only. Pons, cerebellum, as well as subthalamic nucleus. So these are the common anatomical site. Now you may be wondering, we have not mentioned internal capsule area here. This putamen, okay, putamen and thalamus, look how common are they. This internal capsule is present right here. So let's talk a little bit about internal capsule. It has got certain boundaries, the medial boundary and the lateral boundary. Medial boundary is by thalamus and head of the caudate nucleus. The lateral boundary is by, okay, globus pallidus and the putamen. Those are the part of lentiform nucleus. So that internal capsule is one of the very common site for, okay, stroke. That's why I am bringing that point here. Now, what are the risk factors for hemorrhagic stroke? Now let's analyze them. Hypertension tops the list. In 80% of the case, hypertension is the risk factor. There is no doubt about it. The name itself is hemorrhagic type of stroke. So hypertension will lead to rupture of a small blood vessel inside the brain, which is supplying some vital structures, leading to stroke. AV malformation or arteriovenous malformations may rupture again. Bleeding diathesis or bleeding disorder. Okay, so many different examples you can give here. They can also cause the same problem like ITP. Okay, idiopathic thrombocytopenic purpura is one of the important, okay, point there. The important condition. ITP, TTP is another one. Okay, aplastic anemia, leukemia, and those are the things. Amyloid angiopathy. Amyloid angiopathy is the deposition of abnormal substance known as amyloid, which will make that blood vessel weaker at that particular area, and it may bleed. Some of the drug abuse like alcohol, amphetamine, or cocaine. Amphetamine and cocaine are sympathomimetic drugs. They can elevate the blood pressure, and with the hypertension, what they cause, there may be a chance of hemorrhagic stroke. Now let's go to the important part. What are the clinical features of hemorrhagic stroke patient? And we need to compare this type of presentation with ischemic stroke. The onset of the symptom of intracerebral hemorrhage is usually during daytime activity with progressive development of the following feature. That progressive means within minutes to hours these features will be developed, like alteration in the level of consciousness. Alteration in the level of consciousness. It may range from drowsiness to coma. Drowsiness to coma. And coma is very common in hemorrhagic type of stroke. Coma is not that common in ischemic stroke until and unless a large area of cerebral hemisphere is affected. But in hemorrhagic stroke, okay, because of the collection of blood clot, there is rise in ICP, all the secondary changes occur, so coma is quite common. Nausea and vomiting, okay, is quite common again because of raised ICP. Headache, okay, headache, very severe type of headache occurs, more severe in subarachnoid hemorrhage than intracerebral hemorrhage. Seizure also occur there, and focal neurological deficit means some signs of paralysis somewhere in the body, maybe cranial nerve, okay, or maybe because of the corticospinal tract involvement, our limbs or one half of the body. So these are some of the important clinical feature of hemorrhagic stroke. Okay, so let's move on. What are the investigation we like to do to confirm hemorrhagic stroke? Every student can answer this, and the answer is CT scan. It is CT scan. This is called plain CT scan or non-contrast CT scan. Whenever you suspect a patient with a stroke, quickly arrange for CT scan of the head, and that will clearly tell you whether this is hemorrhagic stroke or not. So let's talk a little bit about it. CT scan demonstrate the site and size of the hemorrhage. So where exactly inside the brain, okay, the blood clot has collected and how big is it? Presence of mass effect and midline shift. Mass effect and midline shift. Mass effect means, now see, this is a blood clot here. Okay, this is a blood clot. So let me use the pointer. See there, this is a massive blood clot here. This is the midline. This is the midline. See this white line here, okay, midline. If you clearly pay attention here, this midline has been pushed to the opposite side, slightly pushed, and some of the blood is already entered into the ventricle. Okay, this is the lateral ventricle. So blood has already entered into the lateral ventricle, and look, this lateral ventricle looks dilated as well. The another horn of the lateral ventricle on this side is completely obscured by the blood clot. Okay, so probably the drainage of CSF is also blocked by the collection of the blood. So all these different things we can see very clearly in the CT. There is presence of hydrocephalus, and the iodinated contrast may be injected to increase the screening yield for underlying tumor or vascular malformation. Now this iodinated contrast is called contrast enhanced CT scan. Okay, contrast enhanced CT scan, CECT. Now this can be done later on just to make sure whether this is a pure rupture of the blood vessel or it is associated with some other underlying pathology like tumor or vascular malformation. To diagnose that, we need CECT later on, but in the beginning, don't bother about that. You have to go for plain CT scan. Now another, see there, all of you have a look there, please. This is the hemorrhage. Okay, this white, this is called hyperdense lesion. Hyper, because the density in comparison to the normal brain is bright here, so hyperdense. So already this blood has already leaked here. See this? Okay, in this ventricle. This is another hyperdense area. So very easy to diagnose. Nobody can miss it. Now, how to do the management now? Very important part of this topic. Most of these patients have decreased level of consciousness or they are already in coma, and comatose patient cannot protect the airway. So remember this. So how to protect airway in a comatose case? That has to be done by endotracheal intubation. So that's why endotracheal intubation is important here. Put a tube into the trachea, okay, and then secure the airway. Cautiously lower the blood pressure to a mean arterial pressure, okay, of less than 130 millimeter mercury, but avoid excessive hypotension. So same type of concept we have discussed in ischemic stroke management as well. Do not drop the blood pressure suddenly, and you all know the meaning of mean arterial pressure. Okay, mean arterial pressure is the pressure which will drive the blood flow inside the artery. So mean arterial pressure calculation we have studied before, isn't it? So what is mean arterial pressure? How should we calculate it? Yes.
Diastolic blood pressure plus
Diastolic is
1/3
equal
pulse
to
1
pressure.
by 3 pulse pressure.
Very good, very good. I already got the answer. Excellent. Okay, it is diastolic blood pressure plus 1/3 of the pulse pressure. Diastolic blood pressure plus 1/3 of the pulse pressure. So see there, these are the drug: labetalol, nicardipine, and nitroprusside. Most of these are vasodilator. Rapidly stabilize the vital sign and simultaneously acquire the emergent CT scan. We'll do that, and if we have not done this before, okay, Let's do it now. This is very, very important step. Intubate and hyperventilate, especially if raise ICP is high. Hyperventilation is one of the therapy of raise ICP, just to wash out excessive carbon dioxide, and that will not allow the vasodilation inside the cranial cavity. It will help to decrease the intracranial pressure. At the same time, you can give mannitol also. If raise ICP is excessive, mannitol is given. Maintain euvolemia, means normal blood volume is called euvolemia. Do not give excessive sodium as well as water. Use normotonic rather than hypotonic fluid to maintain brain perfusion without exacerbating brain edema. Now, I like to mention some important point here. Many of the doctor or many of the medical students think this patient is in coma, so let's use glucose containing fluid here. Okay, let's use glucose containing fluid because patient needs it. That is absolutely a very, very wrong concept, because that glucose or sugar which is present in the fluid doesn't stay inside the intravascular compartment. It will quickly, okay, diffuse outside, and this is an osmotic substance. So whenever it go, it will draw water along with it. It will draw water along with it. Now we are talking about the case of brain damage now. If that damaged cerebral neurons are attracting more water, or if they are drawing more water inside them, it will further aggravate the situation. It will further cause cerebral edema. So to avoid that situation, you give normotonic fluid. The answer is normal saline or lactated ringer. Normal saline and lactated ringer. Do not give 5% or 10% glucose only. Even if that is given, you can always add a bit of sugar with the normal saline. That is called dextrose normal saline. That can be tried, but do not only give dextrose containing fluid. Now, another one is avoid hyperthermia. Same principle, avoid hyperthermia. Rather than that, we produce therapeutic hypothermia, okay, regarding the head. Correct any coagulopathy with fresh frozen plasma, vitamin K, or platelet transfusion. Easy answer. If it is there, if it is the cause of the bleeding, then you treat accordingly. If ITP is there, you go for the treatment of ITP. Okay. Similarly, if other coagulopathy, for example, liver disease is causing the problem, you give vitamin K, something like that, or even fresh frozen plasma. Initiate phosphoenitoin or other anticonvulsant therapy for seizure activity or lobar hemorrhage, and optionally in other patient. Seizure disorder is very common in space occupying lesion. This is a type of space occupying lesion because blood clot will develop inside the brain. So how to control that? I already discussed this with you. When the seizure is ongoing, you give diazepam to control it, but for a long-term control, you use one of the anticonvulsant drug like phenytoin or phosphoenitoin, and then facilitate the transfer to the operating room or ICU if it is necessary. If the clot is expanding there, okay, if the patient is in deep coma, probably we should need the help of surgery to evacuate that blood clot, and operating room treatment is very much essential that time. And many of these patients are quite sick, so ICU care is necessary. So see that. So these are some of the important points regarding the management of hemorrhagic stroke. Now, what type of surgical care can be done? Few of the explanations are given here. Consider the non-surgical management for patient with minimal neurological deficit or with intracerebral hemorrhage volume less than 10 ml. So this is a less or slight or small amount of blood clot, and there is minimal neurological deficit as well. So you don't need to go for surgical treatment. Whereas consider surgery for patient with cerebellar hemorrhage greater than 3 centimeter. Okay. For patients with intracerebral hemorrhage, which is associated with structural vascular lesion like AB malformation, like brain tumor, okay, or maybe aneurysm, and for young patient with lobar hemorrhage, we have to go for surgical care. And this surgery is done by neurosurgeon. And these days, in many big hospitals, one of the department has to be neurosurgical department, and the doctor there would take care of this type of patient. Now, with this, let's move on to the last part of this big topic and very important one, that is subarachnoid hemorrhage. This is also important from the exam point of view. Now, what is the meaning of subarachnoid hemorrhage? First, this is a bleeding in the subarachnoid space, okay, collection of blood in the subarachnoid space. This is one of the very serious condition where a person complains of dramatic onset of headache. It is written in the textbook like a thunderclap headache or thunderbolt headache. And patients say, doctor, I have never experienced this type of headache before in my life. If this patient is still conscious, okay, that is the point. Many of them are already unconscious, so they cannot even tell what type of headache was there. But if they are still conscious and if they can still speak, they can tell you that severe type of headache. So this is the entry point to subarachnoid hemorrhage topic. This SAH accounts for some 5% of the stroke. So it is a part of the stroke. Now here, what are the underlying causes of subarachnoid hemorrhage? Okay, let's analyze this slide. The most common cause is Berry aneurysm rupture. Almost 70% of the time it is caused by Berry aneurysm or saccular aneurysm. The saccular term is because of the shape, Berry aneurysm. Apart from that, okay, some other causes are AB malformation again, okay, and some idiopathic, we don't know what is the cause, and sometimes rare associations may be there, like bleeding disorder. Mycotic aneurysm. This mycotic aneurysm is associated with infection of the blood vessel wall, mainly bacterial infection. And one of the condition which is associated with this is infective endocarditis. Acute bacterial meningitis can lead to subarachnoid hemorrhage, okay, but that is quite rare. Brain tumor, that can be primary brain tumor or secondary brain tumor. Metastatic melanoma is the example of secondary brain tumor because it has gone inside the brain from somewhere else. Arteritis is vasculitis. SLE is a perfect example. Spinal AB malformation, it will cause spinal hemorrhage only because subarachnoid space is present around the spinal cord also. Coarctation of the aorta. Now, why coarctation of the aorta causes subarachnoid hemorrhage? Yes?
Because the pressure will be increased on the upper limbs.
It causes hypertension in the upper limb.
Upper limb.
Good. Very good answer. Excellent. I'm sure many other students also know this. This is not direct. It leads to hypertension in the upper half of the body, okay, like in the upper limb and head and neck area. As a result of this, there may be a chance of subarachnoid hemorrhage. So this is the explanation. Marfan syndrome and Ehlers-Danlos syndrome, these are other type of connective tissue disorder where a blood vessel wall can become weaker. They can develop aneurysm and they can rupture. Polycystic kidney is one of the association with Berry aneurysm. We have studied that before. Berry aneurysm is commonly found in a patient with polycystic kidney disease. So that's the connection. See there? So give one or two reasons so that you do not forget it easily. That's the way. So the number one or the most important cause is berry aneurysm rupture. Now, what is that berry aneurysm? Okay, and where it is it commonly found inside the brain? Now, see here. This is berry aneurysm. This is a schematic diagram, but a wonderful one. Okay, so it is mainly present at the junction, okay, at the branching point of the blood vessels. This is the branching point. So this berry aneurysm is seen here. This circle of Willis area. Okay, and this is the angiography, which is showing a aneurysm there. Now this is a pathological, okay, picture. See here. This is a real pathological specimen, and this is a schematic diagram. So these are all are different site for berry aneurysm. Look at the branching point again. Wherever the branching points, berry aneurysms are there. And this is circle of Willis. Every student know how to draw it. Okay, so practice it. I've given a question in the last assignment also. So this is how you draw circle of Willis and label it. Every student know what are the different blood vessels that contribute in the formation of circle of Willis. Now, let's talk about what are the clinical feature. The most important clinical feature, everybody know, that is sudden headache, like a thunderbolt headache, and it starts from the occipital area. This is usually followed by vomiting and often by coma. This vomiting and coma is because of raised intracranial pressure. Neck stiffness and positive Kernig sign is seen very commonly here. This is the important point. So let me underline this: neck stiffness and positive Kernig sign. Remember, this is not a case of meningitis. This is not a case of meningoencephalitis or rupture of the brain abscess. This is a case of collection of blood in the subarachnoid space. But that blood is an irritant substance, so it will, okay, it will cause a minor inflammation or irritation on those meninges, those leptomeninges, which leads to presence of signs of meningeal irritation even in this condition. So it is considered one of the very important differential diagnosis of signs of meningeal irritation. Never forget it. Another is papilledema. Now, papilledema is the swelling of optic nerve head, and it is diagnosed by ophthalmoscope. So it is associated with raised ICP again in this case. Okay, and many of the time it is associated with retinal hemorrhage also. Hypertension is a common finding in case of subarachnoid hemorrhage. Patient may be hypertensive. Now there may be two causes of hypertension here. One, patient may be hypertensive from before. Okay, as a result of that, there is rupture of that berry aneurysm, a rupture of a small blood vessel. Another, as a result of raised ICP, which is known as Cushing's triad. Every student know that. So if we analyze, okay, the features of Cushing triad, one of the feature is hypertension. So you can give different reasons for the hypertension here. Seizure, quite common, and occasionally patient may have focal neurological deficit. Now let me highlight on this focal neurological deficit. Now it is not directly caused by blood in subarachnoid space. Rather than that, it will lead to irritation and spasm of the circle of Willis blood vessel. Now remember, circle of Willis is present in the basal surface of the brain inside the subarachnoid space. Whenever there is blood collecting there, it will cause a spasm of that circle of Willis, and most of the area of cerebral hemisphere will be suffering secondarily, and as a result of this there is focal neurological deficit. This is a very important concept to understand. Okay, let's move on. Let's see some of the picture and then we'll talk about the management. Now see here, this is a retinal hemorrhage. You can see retinal hemorrhage. This is called fundoscopy. Here is a optic disc. I cannot see the boundary of the optic disc clearly. So probably some sort of papilledema is already there. Regarding the investigation, CT imaging or CT scan is the initial investigation of choice in any type of stroke. This is the type of stroke we consider. So CT scan is the initial investigation of choice, no doubt about it. It can clearly diagnose the case. Okay, in CT, in the subarachnoid space, star sign is shown. Now let me show you that. See here, this is called star sign. See this, okay, star sign. This is highly suggestive of subarachnoid hemorrhage. See there, this area. Okay, lumbar puncture is not necessary for the diagnosis of subarachnoid hemorrhage once you have already done CT scan. If your examiner asks, because you are undergraduate student, okay, or even when you go for your licensing exam, in that, you know, viva or oral type of exam, if this question is asked, please do not say I want to do lumbar puncture for the diagnosis of subarachnoid hemorrhage, because that may be quite lethal for the patient. Already there is very high intracranial pressure that can lead to cerebral herniation and can lead to death of the patient. And it is not necessary also, because CT scan is very safe. That CT has already given you the diagnosis. Why you want to go for lumbar puncture? That type of question would come. Okay, but in some of the centers, okay, in some of the centers, for because of the some, you know, research purposes, as you know, for study purposes, for example, what happens to the CSF in case of subarachnoid hemorrhage, you can go for lumbar puncture, okay, by measuring the pressure. This is only done by the expert person. Okay, only expert neurologist can do this. If they do, and if they analyze the CSF, then CSF becomes yellow, which is called xanthochromic CSF. Now this xanthochromic CSF is probably because of production of bilirubin there. Okay, because bilirubin will be formed by those RBC which are present there. So this is the explanation. Magnetic resonance angiography can be done generally below 65 years and those patients who are not in coma. So this is another type of investigation. Now this is another CT, which is showing diffuse subarachnoid hemorrhage. So see there, it's everywhere. A bit of star sign is still visible, but most of the subarachnoid space is covered by blood. Blood is seen as a hyperdense lesion in CT, means it looks whitish in comparison to the normal brain density. This is angiography, okay, which is showing a giant, see this, internal carotid artery aneurysm, very big aneurysm. It is much bigger than berry aneurysm. Now, what are the complications of subarachnoid hemorrhage? Blood in the subarachnoid space can lead to hydrocephalus. Hydrocephalus. Now, what is the mechanism of this hydrocephalus? There are two types of hydrocephalus, every student know. This is communicating and non-communicating. But in this condition, okay, in this condition, the communicating hydrocephalus is more common than non-communicating one. And the explanation is the blood which is there in the subarachnoid space probably may block the absorption site of the CSF, which results in excessive collection of CSF in subarachnoid space and leading to communicating hydrocephalus. Another few percentage of the cases may develop even non-communicating or obstructive type of hydrocephalus. A small blood clot is blocking the aqueduct of Sylvius. Diagnosis is simple here. It is done by CT scan, and after that shunting may be required, that is VP shunt. Now, severe arterial spasm, which is visible on the cerebral angiography, okay, it can be controlled by some of the medicine. Now, one of the drug which we can give in this type of situation is a calcium channel blocker, okay, which is called nimodipine. Nimodipine can be given to reverse this arterial spasm. There is a chance of rebleed, and this rebleed can occur within 24 hours, and in 90% of the time the rebleed occurs within 6 months. Okay, so follow-up is very much essential, and this rebleed is again characterized by similar type of symptoms, this dramatic type of headache and all those things which we have just discussed. So rebleed is treated in the same way. Hyponatremia, you have to correct the spelling here, it should be E. Hyponatremia is a common complication because of SIADH. In any type of brain disorder or diseases, syndrome of inappropriate ADH secretion can occur, and that can result in excessive retention of water only, resulting in dilutional hyponatremia. This can further aggravate cerebral edema. So we need to control it, and the way to control it is restrict fluid. Give fluid only 2/3 of the maintenance. You don't need to do anything else. That will take care of hyponatremia. Now the last part for today's class and this topic as well, the management. Identify and treat the causative lesion. If berry aneurysm is there, go for the clipping of berry aneurysm. It is called clipping of the berry aneurysm, okay, which will prevent rebleeding. Treat hydrocephalus by VP shunt if it is already developed, and treat and prevent vasospasm by calcium channel blocker like nimodipine type of drugs. Okay, now see there. So these are a bit of principle, and this is a little bit in detail. The same things are written here. No extra knowledge here. Every student already know them. Let's go through them quickly. ABC, if the patient is in coma, airway, breathing, circulation management, very basic thing. Correct the electrolyte, glucose. If the patient is dehydrated, give fluid and maintain the temperature. Should be on the lower side. Treat blood pressure with antihypertensive drug. Treat vasospasm by nimodipine. Treat the raise ICP by dexamethasone. Even mannitol can be given here, or VP shunt, okay, in case of hydrocephalus. Surgical clipping of the aneurysm in case of berry aneurysm, and some direct surgery, microembolism, and focal radiotherapy, which is known as gamma knife. Okay, this is a type of radiotherapy treatment to destroy that bleeders, or to destroy that bleeding area. Okay, like AB malformation is a bleeding area, isn't it? So we use gamma knife or radiotherapy to destroy it so that the person will recover. So all these are important.